It could be inside the body. This is internal hemorrhage. So it could be external or it could be internal. It could be localized, like in body cavities, or it could be in the subcutaneous tissue, like petechiae, purpura, or ecchymosis, and we will explain that in details when we go further. So accumulation of the blood in pleural cavity, we call it hemothorax. So heme stands for blood, thorax pleural cavity. So hemothorax, accumulation of blood in the pleural cavity. Hemoperitoneum, accumulation of blood in peritoneal cavity, تجويف البطني. Hemopericardium, accumulation of blood in pericardial cavity, تجويف القلبي. Hydrothorax, not heme, hydrothorax is accumulation of what? Accumulation of fluid in the thoracic cavity. The same applies for hydroperitoneum and hydropericardium. Sometimes hemorrhage appear in your body as dots in your skin. This could be called petechiae or purpura or ecchymosis according to the size of hemorrhage. It's very small, pinpoint hemorrhage, we call it petechiae. If it's huge spots in your skin, we call them ecchymosis. Okay. Now, this is, for example, this is a picture for a patient with bleeding disorder. Petechiae, pinpoint hemorrhage, less than 1 to 2 millimeter dots of blood. If they are a little bit larger, we call them purpura. And if you had huge spots, everybody at one point of his or her life will experience this lesion, like ecchymosis. If you hit your arm, for example, or your leg to a solid object, you will get ecchymosis. So ecchymosis is a sign of bleeding. It could be due to trauma, for example. It could be due to bleeding disorder. But this is what this is: accumulation of blood wear in the subcutaneous tissue beneath the skin. So all of these are signs of hemorrhage. Okay. We go back to terminology. Hemoptysis. Hem stands for blood. Hemoptysis, coughing of blood. Hematemesis, vomiting of the blood. Hematoglycia, fresh blood in the stool. And melena is all the blood in the stool. So if you have, for example, hemorrhage or hemorrhoids, basur, hemorrhoids, this will be associated with the bleeding of fresh blood in the stool and this hematoglycia. But if you have, for example, GI bleeding, نزيف في الجهاز الهضمي, okay, like patient with peptic ulcer disease, قرحة معوية, and bleeding in the GI tract because of blood become oxidated during its journey to be shed in the stool, it will become a black in color, and we call it what? Melena. Hematuria, blood in urine. Metrorrhagia, excessive menses. Okay, so all of these are signs of what? Of bleeding disorders. So symptoms and signs of blood loss: if it's rapid loss of more than 20% of your blood, this will lead to hypovolemia. Okay, more than 20%, less than 20% usually is compensatable. You can replace this amount and you can stand this amount. Massive blood, we said, lead to hypovolemia and shock. What's shock? Is a state of hypotension and loss of consciousness. Okay. However, chronic loss may lead to anemia, decrease in hemoglobin. Hemostasis and thrombosis. We said hemostasis, balance, to keep the blood balanced. It means to keep the blood within the circulation without clots. So this is physiological process. However, thrombosis is pathological process. We said the thrombosis, to have a clot within the circulation. If you have a clot, khethra, within the blood vessel, this is called a thrombus, pathologic. But hemostasis, we said, is to have a clot at the site of injury to stop blood loss. So this is physiologic. This is hemostasis, and the process the body takes to form a clot, we call it coagulation. عملية التجلط أو عملية التخثر. And you have two parts for coagulation process: primary hemostasis and secondary hemostasis. Primary, this is the formation of unstable clot. الخثرة البدائية. When you stabilize the clot, you will start the process of secondary hemostasis. The goal of secondary hemostasis is to stabilize the process and to form a permanent clot. خثرة دائمة. And you can see it in your daily life. If you have, for example, an injury and you press at the site of injury for example, 30 seconds, 1 minute, and you remove your finger, you will end with having a clot. راح يتوقف الدم. But if you try to move the clot or to scratch the site of injury, you will have a rebleeding. راح ينزف من جديد الجرح. Why? Because this is a primary hemostasis. But after 3, 4, 5 days, when the permanent clot is formed, even if you scratch the site of injury, the blood will not go out again. Why? Because you having now what? A secondary or a permanent. So hemostasis, it has 3 separate stages, okay? It has a vascular stage phase, it has a platelet phase, and it has a coagulation phase. Let's suppose this is a blood vessel and you have injury in the blood vessel, loss of the endothelium. The first thing the body, and this is the blood flow, when you have injury, some of the blood will go outside. The first thing the body takes to decrease blood loss is vasoconstriction. The body tries to constrict the site of injury. Why? Because this is rapid process to decrease the blood loss. So this is the first stage, the first phase, vascular phase, vasoconstriction. But this is not enough, because even with vascular constriction you cannot stop blood loss. So it will start, the body will start the second stage, which is the platelet stage or the primary hemostasis. In the platelet stage, the platelets will become and fill the gap of the injured blood vessels to stop blood loss, okay? But again, this is not stable. Why? Because you don't have anything to support the platelets together. You don't have a glue-like material, مادة لاصقة, to support the platelets together. So this is the primary hemostasis. Once you fix platelets together by fibrin, which is thrombin, which is a glue-like material, كالمادة اللاصقة, you will end with coagulation. So you have injury of the blood vessel. The first phase is vasoconstriction or vascular spasm. This is the first step in hemostasis, but this is not enough, and you cannot stop blood loss. So you will come, this is the vascular phase, then you will start with the second phase, which is the platelet phase. You will bring platelets at the site of injury to decrease blood loss. But again, platelets are not stable. Why? Because you don't have anything that brings the platelet together. So you will start the coagulation pathway to produce what? To produce fibrin. What's fibrin? It's a protein with sticky features. protein له خصائص لاصقة. So fibrin will brings platelet together and forms a permanent clot. So this is the last phase in coagulation, which is in coagulation, which is the coagulation phase or fibrinogen phase. Okay. Now we said you wanted to produce fibrin. Why? To form a permanent clot. Okay. How the body produce fibrin, which is a protein? Fibrin is found in your circulation as fibrinogen, which is inactive. How you can transform fibrinogen inactive into fibrin? You need a protein or enzyme. It's called thrombin. But thrombin again in your body is found inactive as prothrombin. How you can convert prothrombin into thrombin? This is by the activation of factor 10. Factor 10 found in the circulation, this is Latin number, X stands for 10. Found in circulation inactive, غير نشط. To activate factor 10, you need another factor, which is either factor 7 or factor 9. So, factor 10 can activate factor 2, and factor 2 can activate factor 1, which is fibrinogen. How you can activate factor 10? We said you need either factor 7 or factor 9. So you have two pathways to activate factor 10. either extrinsic pathway, which starts with factor 7, or intrinsic pathway, which starts with factor 12. Why we call it this extrinsic pathway? Because factor 7, it's activated by something found outside the vascular spaces. Why we call this intrinsic pathway? Because factor 12 is activated by something found within the vascular spaces. Once you activate factor 7, this will activate factor 10. Once you activate factor 12, this will activate factor 11, and factor 11 will activate factor 9, and factor 9 will activate factor 10. Then you will activate factor 2, and then you will activate factor 1 and produce fibroid, which is active factor 1. Now the vascular space, we said the first phase in coagulation is vascular phase, which is vasoconstriction, and how the blood vessels become constructed is under effect of, for example, ADP, tissue factor, prostacyclin, usually causing vasodilatation. So in hemostasis you will have inhibition for prostacyclins, and you have activation for ADP and thromboxane. That will lead to suction. Okay, you don't have to remember everything related to this image, but this is to show you that endothelial cell, it has too many functions, uncountable functions. Some of the functions will increase coagulation, other functions coagulation. The platelet phase, in the platelet phase, you bring platelet at the site of injury under the effect, for example, of thromboxane A2, which will lead to vasoconstriction and platelet aggregation, under the effect of ADP, that will lead to platelet aggregation. Okay, now again, the platelet in your circulation, they are found inactive, غير نشيطين, and under the effect of thromboxane A2, platelet drive growth factor, ADP, this will activate the platelet and will bring them at the site. Okay, but this will lead to primary hemostasis, primary clot. Is it stable clot? No, it's not stable clot. Why? Because we said we don't, in this state, you don't have production of fibrin, so platelets are not sticky to each other. But this will prevent blood loss, at least initially. How we activate the platelets? We said under the effect of ADP, thromboxane A2, or calcium. This will activate platelets and they become sticky to the site of injury and they will clot. This is the platelet phase. We said in the platelet phase, you bring platelets at the site of injury to form a clot. This is a clot. This is a primary clot. Why? Because you don't have fibrin that brings or strengthen platelets together. How you activate the platelets? Under the effect of ADP, platelet drive growth factor, thromboxane A2, and calcium. This is a cartoon to show you how platelets become sticky to the site of injury. Let's suppose this is the endothelial lining. Normally, the endothelium should be continuous. Once you have injury, we said the platelets in the circulation, they are found inactive. So this platelet cannot become sticky or adherent to the surface of the endothelium. Why? Because this is inactive platelet. The inactive platelet does not have pseudopods, أقدام كاذبة, or receptors to become adherent to the endothelium. But once you have injury of the endothelium, you will expose platelets to the subendothelial tissue. Subendothelial, تحت الانdothelium, you have collagen and you have what we call a tissue factor. Tissue factor and collagen proteins found subendothelium, تحت الانdothelium. And in addition to tissue factor and collagen, you have Van Willebrand factor, VWF, Van Willebrand factor. Van Willebrand factor is found subendothelium. And Van Willebrand factor, it serves as receptors for what? Serve as receptor for platelet. So once you have injury, you'll have activation of the platelet and pseudopod al-aqdam al-kadhiba start to appear. How you activate? We said the platelet by thromboxane A2, by ADP, by calcium. So once you activate the platelets, those pseudobodies become apparent and become adherent to Van Willebrand factor, which is found sub-endothelium, تحت الendothelium. So normal endothelium will prevent platelet from adhesion, but once you have injury to the endothelium, you have exposure to Van Willebrand factor, and this will lead to platelet adhesion. And the receptors found at the surface of the platelets, we call them glycoprotein 1b. So glycoprotein 1b is the platelet component that become adherent to Van Willebrand factor. Okay, so we call this process platelet adhesion or primary clot. This is the difference between resting inactive platelet, inactive, and what active platelet. Look, for active platelet you have now what you have pseudobodies where there's a glycoprotein 1b that become adherent to Van Willebrand factor, which is found in the subendothelium. Okay, so and you have the coagulation phase. What's the aim of coagulation phase? Is to produce what? Fibrin. And why we need fibrin? We said fibrin, it's a glue-like material to bring the platelets, to strengthen the platelets together. So now you have platelets forming a clot, and you put fibrin in between. Why you put fibrin in between? To make the clot strong enough and secondary hemostasis. Okay, so this is coagulation pathway. Coagulation pathway or coagulation cascade المتسلسل. It's a process. In this process, once you activate the first protein, you will have a cascade متسلسلة. This protein will activate the second protein and the third protein, the fourth protein, until you activate the last protein. We said in coagulation pathway we wanted to produce fibrin, which is factor what? Factor 1. To produce fibrin, we wanted to activate factor 2, which is the thrombin. To activate factor 2, we wanted to activate factor 10. So activation of factor 10 will activate factor 2, factor 2 will activate factor 1 or fibrinogen that will produce fibrin, and now you put fibrin between platelets and you form what? A permanent clot. And look at the fibrin, it's mesh work of proteins that brings platelet together. Okay, so the aim of coagulation pathway is to produce what? Fiber-like material. And these are the stages or the phases of hemostasis. We said with vasoconstriction at the site of injury, then the platelet adhesion, the Van Willebrand factor and the platelets. Then you produce fibrin that form the permanent clot. Then you lyse extra fibrin because you don't want to build too much platelets, too many platelets that exclude the blood vessel. Once you have a clot obstructing the injury, حينما تكون خثرة مناسبة لمكان الجرح. Okay, once you have a clot suitable for the site of injury, you want to lyse extra fibrin. يجب أن تتخلص من الفايبرين الزاد عن الحاجة. Why? Not to form a clot that occludes the blood vessel. Okay, so the last step in hemostasis is fibrinolysis. Fibrinolysis, lysis of extra. How you activate the clot pathway? You have two pathways, extrinsic or intrinsic. We said you wanted to activate factor 10. This is factor 10 inactive. Once it's active, we put A, small a. So active 10 with A, this is active factor 10. If you activate factor 10, factor 10 will activate factor 2, and factor 2 will activate factor 1 to produce what? Fibrin. How you activate factor 10? We said two pathways. Either by activating factor 12, X11, this is factor 12, or by activating factor 7. If you activate factor 12, this is intrinsic pathway. And why we call it intrinsic pathway? Because activation of factor 12 occurs by components within the blood, within the circulation. So this is intrinsic pathway. But if you start with activating factor 7, this is extrinsic pathway, because activation of factor 7 occurs through tissue factor. And if you remember, we said tissue factor is found where? In the subendothelium. Okay, so it is found outside the circulation. So we call this extrinsic pathway. So you have intrinsic pathway, extrinsic pathway starts with factor 7, intrinsic pathway starts with factor 12, and you have common pathway which starts with factor 10. So you have extrinsic, intrinsic, and common. It says extrinsic pathway, intrinsic pathway meets at factor common pathway. So common pathway starts with factor 10, then factor 10 will activate factor 2, and factor 2 will activate factor 1, prothrombin to produce what? Or fibrinogen to produce what? Fibrin to form community clot. So this is the summary. Common pathway which starts with factor 10. Why we call it common pathway? Because you can activate factor 10 either by intrinsic pathway, activation of factor 12, or by activation of factor 7 by tissue factor. Tissue factor found in beneath the endothelium. So a tissue factor found outside the circulation, so we call it extrinsic pathway. This one we call it intrinsic pathway. They meet at factor 10. Factor 10 will activate factor 2, factor 2 will activate factor 1, then you will produce what? Fibrin. That will form a mesh, hard mesh between the platelets to form the permanent clot. Okay, so if you have a patient with loose clots, عدم تجلط دم, loose clot, the problem could be in the platelets, الصفائح الدموية, or coagulation proteins, عوامل التجلط. Okay, so the problem could be in factor 2, factor 1, factor 10, factor 8, factor 7, factor 9, regardless the factor. So if you have deficiency, decrease in clotting factors, عوامل التجلط, the patient will get what? Decrease in clotting factors, the patient will get bleeding disorder. So مرض نزف. Why? Because you don't have clotting factors. Bleeding. This is the fibrin meshwork that brings platelets together and make them strong. Then once you activated thrombin, and as you have activators for the coagulation pathway, you will have inhibitors. For example, for thrombin, which is an activator, you have antithrombin, which is inhibitor. Okay, for tissue factor, which is an activator, you have tissue factor pathway, which is an inhibitor. Okay, so you have activators and to control the process of coagulation. And we said the last step in hemostasis is fibrinolysis. You lyse extra fibrin by the effect of plasmin. So plasmin will lyse fibrin, extra fibrin, and you have inhibitor for plasmin, which is antiplasmin. For any step of activation, you have an inhibitor step. So you have activators, inhibitors. And for this slide, it looks complicated, but again, you don't have to remember the right side of this slide because it's not included for you, but you have to read and remember the left side with all the notes in beneath. These are very important notes, and you have about these notes, just let me know. Now, what lab test you use to assess for coagulation? For example, if you have a patient with a bleeding disorder or thrombotic disorder, what lab test do you ask for to assess for his problem? We said for bleeding disorders, or what control clot formation is the presence of platelets, is the presence of coagulation factors. So if you have a patient with a bleeding disorder, the problem either in the platelets or you have the intrinsic pathway. For that reason, you should have two tests. One to assess for the intrinsic pathway, which we call PTT test, partial thromboplastin time test. Sorry, and one to assess for the extrinsic pathway, which we call PT test. So to summarize, we have the platelet phase and coagulation phase. The platelet phase, you have two tests for that phase. The platelet count, which is a quantitative test, and the bleeding time, which is a qualitative test to assess for the quality of the platelet. For the coagulation phase, you have two tests. You have the PTT test, which is assessing the intrinsic pathway, and you have the PT test, extrinsic pathway. To remind you, coagulation pathways meet at the common pathway at factor 10. We said once you activate factor 10, this will activate factor 2, prothrombin or thrombin will activate fibrinogen, which is factor 1. Sorry, that will produce fibrin that will form the permanent clot. You activate factor 10 either by intrinsic pathway or by extrinsic pathway. We said PT test, it assesses the extrinsic pathway. In other words, PT is the time taken by extrinsic pathway to form what? To form fibrin. And PTT, it's the time taken by intrinsic pathway to form fibrin. For extrinsic pathway, the body needs 12 seconds to form what? Fibrins. For the intrinsic pathway, the body needs almost 45 seconds to form fibrin. So PT or PTT, those tests assessing the time needs by the body to form fibrin, either by activation of factor 7 in extrinsic pathway or activation of factor 12 in intrinsic pathway. So these are examples for when you get abnormal result, for example for PT, PTT, or for platelet count or for platelet function. If you have deficiency in factor 7, this will lead to prolongation in PT time. Instead of having 12 seconds to form fibrin, the body needs, for example, 1 minute to form fibrin if you have deficiency in factor 7. What factors deficiency may lead to prolongation in PTT? Intrinsic pathway factors, okay? What factors lead to prolongation in both PT and PTT? Common pathway factors, factor 10, factor 2, factor 1, and factor. These are some of the diseases that lead to bleeding disorders. Amrad nazif, bleeding disorders. For example, in hemophilia, you have deficiency in hemophilia A or B. You have deficiency, for example, in either factor 8 or factor 9. Factor 8 or 9 deficiency will lead to prolongation in what? In PTT. What about PT? They are normal. Why PT is normal? Because factor 8 or 9, they belong to intrinsic pathway. Bleeding time will not be affected because bleeding time assess what? Platelet function. Platelet count will not be affected because this is related to coagulation. It's a disorder in coagulation factors, not platelet. Okay. What about, for example, aspirin? Aspirin will decrease production of cyclooxygenases and prostacyclin. So aspirin will lead to qualitative abnormality in the platelet. So this aspirin will lead to a prolongation in bleeding time, but will not affect any other times. Thrombocytopenia, low platelet count. This will lead to decrease in platelet count and increase in platelet time. It will affect the function and the quantity, because if you have low platelet count, definitely this will lead to a prolongation in bleeding time. But in what it will not affect PT or. Okay. Now we'll talk about thrombosis. We said thrombosis jalta is something pathologic. Why? Because you have a clot, khatra, occluding the circulation. Thrombosis could be arterial if you have a thrombus occluding an artery, or venous if you have a clot occluding what? A vein. What may lead to thrombus formation? ما الذي يؤدي لتكون الجلطة? Because thrombus is pathologic, so what leads to thrombus formation should be something abnormal, either in the blood composition, for example, the platelets or the coagulation factors, or blood circulation if you have stasis in the blood or slow circulation, or in the vascular component in the endothelium itself. If you have abnormality on one of these components, this will lead to thrombus formation. Okay. For example, we said thrombosis is pathologic if you have a clot within the circulation. What causes a clot? Either endothelial injury or stasis or hypercoagulability. Blood components, blood circulation, or the endothelium. Okay. Acquired factor for thrombosis. Acquired, مكتسبة from the surrounding. But sometimes you have congenital factors for thrombosis. When I say congenital, they are inheritable causes. Protein C, protein S, they are inhibitors of coagulation. So if you have deficiency in the inhibitors, protein C is inhibitor. If you have deficiency in the inhibitor, this will lead to increase in coagulation. Protein S is inhibitor. If you have deficiency in the inhibitor, this will lead to increase in coagulation. The same thing for antithrombin. Antithrombin is inhibitor for thrombin. If you have deficiency in antithrombin, this will lead to increase in coagulation. Okay, these are congenital causes. We said thrombosis could be either arterial thrombus or venous thrombus. If you have arterial thrombus, for example, this will lead to ischemia or infarction. Ischemia, decreased blood supply to an organ. Infarction, complete loss of blood supply. And myocardial infarction, جلطة القلب, is arterial because you occlude the coronary arteries, one of the coronary arteries. This will lead to decrease of blood, oxygenated blood to the heart. So this is infarction, and you can get venous thrombosis if you have in the vein. This is, for example, a blood vessel, and inside the blood vessel you have what? A thrombus, jalta, a thrombus. If the thrombus includes more than 75% of the blood, of the diameter, of the blood vessel, this will lead to infarction, death of the tissue. Sometimes you can get recanalization in the thrombus by lysing fibrin. This will let blood to go back to the organ. Sometimes you have organization, the clot includes the whole circle. So this will lead to catastrophic result. So fate of thrombi, ما هي نهاية thrombus? Either resolution, lysis, propagation, increasing in size, organization, become fixed to the site, or embolization. If you have, for example, this is a blood vessel and you have a thrombus in the blood vessel. If part of this thrombus became detached and circulates in the blood vessels, this is embolization. When you have small part become detached from the thrombus that circulate in the vessels and go to other part of the bodies. Okay, this is embolization. You have different types of embolus. Anything foreign to the circulation may form an embolus, like air emboli, air bubbles, فقاعات الهواء, they may interfere with the circulation. Fat emboli, thromboemboli if it's part of the thrombus. For example, if you have, this is head of the patient, this is the neck, and this is the heart. Heart gives blood to the head and neck and to the peripheral circulation. If you have embolus, thrombus in the heart, part of the thrombus will form an embolus, will go to where? To the brain circulation. This is, we call it cerebral ischemia, cerebral infarction, جلطة دماغية. So from where it came from the heart. So this is systemic embolization. What about pulmonary embolization? The same patient or another patient, you have the lung, okay? You have lungs and you have lower limbs, for example. If you have this patient having a thrombus in the lower limb, in the veins of the lower limb, part of this thrombus will become detached and it will go back through inferior vena cava to where? To the right side of the heart. Okay, it's small, so it would not affect or will not make anything wrong to the heart, but from the right side it will go back it will be pumped from the right atrium to the right ventricle, and the right ventricle will pump it to the lung. Okay, now in the lung it may occlude one of the blood vessels in the lung. This will lead to pulmonary embolism. So I will make this more clear. I'm sorry for that. Okay, so this is the heart, and these are the lower limbs, and this is the lung. Okay, we said if you have a thrombus in the lower limb, in the veins of the lower limb, this will lead to swelling in the lower limb. Part of the thrombus, we call it impulse, will become detached and will go back to the right side of the heart. Right side of the heart will pump blood where? To the lung. So this is small impulse will not cause nothing wrong, will not be harmful to the heart, but will be harmful to the lung. Why? Because the blood vessels inside the lung are smaller than heart chambers. So this small impulse may occlude one of the blood vessels in the lung. This will lead to pulmonary embolism, and the patient will complain of shortness of breath. Okay, so this is a thrombus blood vessel. We said in the lower limbs, if you get thrombus, venous thrombus, this will lead to swelling and premature escalation of the lower limb. If this thrombus detached, part of this thrombus became detached and go to the lung, this will lead to pulmonary embolism. And this is the part of the lung, this is the lung, and you have a thrombus or an impulse where in the pulmonary circulation. This is pulmonary embolism. What are signs of pulmonary embolism? Shortness of breath, difficulty in breathing, and prior to that the patient will have DVT, deep vein thrombosis, a thrombus in the deep veins of the leg. Okay, now what's infarction? We said if you have a blood vessel occluded by a thrombus, if the thrombus block blood supply more than 75% of blood supply to that organ, this will lead to infarction. Okay, so death of the tissue, not because of the decrease to that organ. So infarction, you have, for example, myocardial infarction, you have pulmonary infarction, you have kidney infarction. Any organ suffered from low blood supply become infarcted. Now, if the heart became infarcted, we said the function of the heart is pumping blood. If the heart became infarcted, so part of the heart is not functioning, so the amount of blood pumped by the heart will decrease. So decreased blood supply to the brain will lead to hypoperfusion and loss of consciousness, or other words, will lead to shock, a sudden shock. So shock is a state of perfusion. What may lead to hypoperfusion? Decreased blood supply, decreased blood pressure. It could be cardiogenic. We said if there's a problem in the heart is not pumping, this is cardiogenic shock. Sometimes if you lose too much of blood, more than 20% of blood in your circulation, this will lead to hypovolemic shock, loss of consciousness because decreased blood volume. Septic shock. If you have septicemia or infection may lead to vasodilation of blood vessels. If you have vasodilation of blood vessels, the amount of blood going back to the heart will decrease. Why? Because you have vasodilatation and the blood will stay in the blood vessels. So less blood supply, less blood return to the heart. So this is septic shock. Anaphylactic shock is due to, again, vasodilatation and increased vagal stimulation, and neurogenic shock, again, because of increasing parasympathetic stimulation. So shock is a state of hypoperfusion or hypotension associated with loss of consciousness. What may lead to shock? decreased volume, hypovolemic shock, or problem in the heart failure, or vasodilatation, regardless of the cause of vasodilatation. So shock is loss of consciousness because of decreased blood flow or supply to the brain, regardless the cause. Okay. Well, these are types of shocks: cardiogenic shock and hypotonic shock. Could be